Okay, so do you want me to start? Can I start?
Yes, please.
Okay, so this lecture is basically gonna cover, I was supposed to do the second lecture only of cardiac and vascular function curves, but because the lecture got delayed, I figured I would make my own presentation of both the lectures put together, and just to like give you a summary of what you need to know exactly. I'm not gonna go through the lecture slide by slide. I don't think that's useful. So I've just made a summary of about 10-15 slides, and we're just going to go through them, and they should cover the most important stuff from both the lectures of cardiac function and vascular function curve or venous function curve. Before I start, these are some equations you need to know. My focus, the focus of this session will not be on these equations because you should know them already, but just to look through them, let's let's start with this third equation, okay? This is called Poiseuille's law. This is flow Q. Flow occurs down a pressure gradient. P1 minus P2 means the pressure gradient. P1 is upstream pressure. P2 is downstream pressure. And flow occurs from P1 to P2, okay? Okay. So flow occurs down a pressure gradient. If I have a tube, this is upstream pressure, this is downstream pressure. Flow will occur this way from P1 to P2. Resistance is the amount of compression on that vessel, basically. Resistance is viscosity times length over radius to the fourth power. Now, from this equation, you can see that radius to the fourth power is the biggest determinant of resistance. So for example, if radius is changed by 2, so 2 to the power 4 will be 16. That means resistance will be changed by 16. Okay. And radius is inversely proportional to resistance. So if I increase the radius of a vessel by 2-fold, I will lower the resistance by 16. That's one important concept you need to know. Second concept is, if you rearrange this equation, you will get pressure gradient equals Q times R. So I've just multiplied both sides by R and made pressure the subject, right? Now from this, you can see that resistance and pressure are directly related. What do I mean? If I mean this is a vessel here, and this is P1, this is P2, this will be resistance here, the amount of compression on that vessel, which is radius, right? If I increase resistance on this vessel, if I constrict this vessel, P1 will increase because blood will back up. P2 will decrease because blood can't flow through to P2. So upstream pressure increases, downstream pressure increases. So that means that the pressure gradient increases. That's the second important concept you need to know, okay? Because now you know that if delta P, or the pressure difference, is proportional to radius, if by looking at the changes in pressure across the circulatory system, okay, just let me explain, then I'll get to it, okay? Basically, what I've done is I've rearranged this equation, flow equals this equation here, for pressure. So I've made pressure the subject, okay? So I've made it like delta P equals, I've moved R to the other side, and I've made P the subject. That means resistance is directly related to pressure gradient, okay? So what that means is, as resistance increases, pressure gradient will increase. Why is that significant? Because you will see this diagram in your other lectures about pressure, and this will be changes in pressure throughout the circulation. The biggest change in pressure throughout the circulation will occur at the arterioles. If the biggest change in pressure, or the biggest pressure gradient, is across the arterioles, and the pressure gradient is directly related to resistance, that means that arterioles are the main resistors of the blood. Okay, so that's a major concept you need to know. Arterioles is where resistance happens, vasoconstriction, vasodilation. The second equation that you need to be familiar with is compliance. So compliance equals volume over pressure, okay? Let me erase some of this. So compliance equals volume over pressure. What does that mean? That means if I have a tube, let's say I have a very rigid tube and I fill it up with blood. If that tube, some tubes are very elastic or stretchable, let's say. Some tubes, when I put the blood in, they will stretch and they will accommodate that entire volume without a big change in pressure. But if I have a very rigid tube, even if I put a little bit of fluid in, then the pressure will rise very much. So this equation you need to know because we'll come back to it later on. Also, if you rearrange the equation, then you will get pressure equals volume over compliance. So just remember this concept as well. This is very important, okay? Now, when we're talking about cardiac function, I'll begin with cardiac function, then go on to venous function. There's two things in cardiac function. We're talking about systole, that's the first thing. The next question is what happens during systole? So I think most of you know this, but we're gonna start from the basics. In systole, the heart will pressurize, contract, and it will eject, okay? The heart will pressurize and it will eject. That means that if the heart pressurizes and ejects, I need to find a way to measure how good the heart is functioning. So what I can do is I can measure the amount of volume the heart ejects. That volume is called stroke volume. Because the heart is pressurizing and ejecting during systole, if I measure the amount of volume the heart is ejecting, that gives me an idea of systolic function. Okay, so stroke volume is the major way we can figure out if systolic function is normal or systolic function is abnormal. So that's the first thing, okay? What other way can we use? We can use cardiac output, right? And the reason I'm telling you all of this is maybe you think, well, how is this related? The reason I'm telling you is that we look at a lot of graphs later on. And on the y-axis of the graph, sometimes you'll see stroke volume, sometimes you'll see cardiac output. They mean the same thing, okay? They're all measures of systolic function. What we're concerned of is systolic function. Stroke volume is the major one we'll discuss during this section on cardiac function. So systolic function, stroke volume is the major way we figure out systolic function. That's one concept. The next question you should ask is what regulates stroke volume? Because the things which regulate stroke volume will give us an idea of systolic function. We need to know how they regulate stroke volume, why do they regulate stroke volume, and what changes do they cause to cardiac function, okay? So, and you need to know this probably will be in your exam. Stroke volume is determined by preload, contractility, and afterload, okay? Again, stroke volume is used to evaluate systolic function. Stroke volume itself is controlled by preload, contractility, afterload. The mnemonic I use to remember this is CAP, right? So preload, contractility, afterload. This is how we'll discuss them. So when we're looking at cardiac function, okay, so there's some comments. You're ahead of me in the lecture. So we'll discuss all of them, but right now we're building basic concepts, okay? You'll see how all of this relates to what you're saying, okay? So when we're looking at cardiac function, we'll look at preload, then we'll look at contractility, then we'll look at afterload, okay? So let's start with preload. Do any of you remember this curve on the left? You saw this curve in MSK. This is called length tension relationship. What it tells you is that the more you stretch the muscle, the skeletal muscle, the more the more force it generates when it contracts. Okay, so if you're looking at my biceps is down. If my elbow is flexed, my biceps is shortened, so I can't generate a great force. But if I lengthen out my bicep and then generate a force, that force will be greater. Okay, so this is length tension relationship. The greater the length, the more the greater the contraction. This, however, occurs up to a point. If I go beyond a length of muscle stretch, the muscle fibers will overstretch and my tension will fall, right? So the more the length, the better the contraction. However, beyond a certain point, the muscle fibers get overstretched and you lose tension. The heart is the same, okay? But heart is not attached to a tendon, to a bone. So heart, the stretch on the heart is determined by the amount of fluid inside the heart. If more fluid comes into the heart will stretch more, it will contract more, okay? And this is the same relationship. The length tension relationship in the heart is called Frank-Starling. It's the same relationship that if you look here, the volume inside the heart at the end of diastole, as it increases, the heart will stretch, the ventricle will stretch, it will contract to generate a greater force, okay? Intraventricular pressure, stroke volume, cardiac output, they mean the same thing, okay? Don't get confused by the axis. The more I have volume, the more stretch I have, the better the contraction. However, again, this contraction occurs up to a point. If I go beyond a volume, the cardiac fibers will overstretch and I will lose contraction. Okay, so I will lose stroke volume, I will lose cardiac output. Now, that's the first concept. Length tension relationship shows you that muscle length determines contraction. Length tension relationship in the heart is called Frank-Starling. The heart, the length of the heart of the cardiac muscle fibers is determined by the amount of volume. The more volume you have, the more the stretch. The more the stretch, the better the contraction. Now I'm going to explain something and you tell me if this makes sense. Venous return determines the amount of preload on the heart. Does that make sense to everyone? Yes. Venous return determines the amount of preload to the heart because venous return determines the amount of blood coming back to the heart. The more venous return you have, the more blood comes into the heart. The more that blood comes into the heart, the more the heart stretches. The more the heart stretches, the better it contracts. So venous return changes cardiac output by Frank-Starling mechanism. Does that make sense? Okay. So venous return alters cardiac output by Frank-Starling. Now, that's preload. We've done preload, okay? We said that 3 factors alter stroke volume: preload, contractility, afterload, CAP. We've discussed preload, and we need to know from preload, you need to know that the more it stretches, the more contraction you have. This is called Frank-Starling. Preload is determined by venous return. That's all you need to know for preload, okay? Now, let's move on to contractility. Contractility is defined as changing cardiac output or stroke volume, the systolic measure of systolic function, without changing preload, okay? So, for example, if this is preload here, this is the amount of volume in the ventricle. If I'm going along this curve, this normal cardiac function curve, for example, I go from this point to this point. Preload increases, stroke volume increases. This means that this change is because of Frank-Starling, because preload increased, volume increased, contraction increased. However, contractility is me changing stroke volume without changing preload. So I have to go from here to here. From here, or this would be an increase in contractility now. So you notice if this is a preload of, let's say this is 3 here. At preload of 3, I'm getting a greater contraction. That means I altered contractility. So contractility changes contractility will shift the curve up or down, or to the left or to the right. Okay. How can you change the contractility without a change in preload? I'll show you. Now, contractility, what determines contractility now? I've shown you what contractility is. It's changing cardiac output without changing preload. The next question is, what regulates contractility? These two things are the ones you need to know. Sympathetic nervous system is the major one, and then digitalis is the other one, okay? So contractility, changing cardiac output without changing preload. What regulates it? Sympathetics and drugs like digoxin or digitalis. Contractility is determined by the amount of calcium in the muscle. These two factors, sympathetic nervous system stimulation and digitalis, they increase amount of intracellular calcium. The more calcium you have, the more contraction you will have. So the contractility will increase. The preload won't change, okay? So in the exam, what they can tell you is, they can give you a scenario where they show you this curve of normal cardiac function. They put a point here called A. They put another point here called A2. And they put a point here called B. So, and they will ask you what would change A to A2, or what mechanism does this show you? You would say this is Frank Starling, because preload is increasing, stroke volume is increasing. That means this is Frank Starling. What would shift the curve from point A to point B? You would say an increase in contractility, because preload is not changing, but cardiac output is changing. That means I altered contractility. So that's the second point. So again, we discussed initially that stroke volume is the major indicator we'll use of cardiac output, of cardiac function. Three things alter stroke volume: preload, determined by venous return and by Frank Starling mechanism. Number two, contractility. Contractility is me increasing or decreasing cardiac output without changing preload. It's altered by the sympathetic nervous system and by drugs like digitalis. Does it make sense up till now?
Yes.
Okay. So preload is done, contractility is done. The next question is afterload. So afterload is the amount of pressure that the heart must eject against. How I like to think about this is, you remember that flow equation that we had? So P1 minus P2 over R, right? Now contextualize this equation to the heart. P1 would be the pressure inside the left ventricle. P2 would be the mean arterial pressure. If mean arterial pressure increases, that means the pressure gradient decreases. If pressure gradient decreases, that means the cardiac output will decrease, because cardiac output in this setting would be flow. Okay, so the afterload is the pressure that the heart is ejecting against. Afterload is the pressure that the heart is ejecting against, is determined by the mean arterial pressure. Okay, so for example, in hypertension, you have a high blood pressure. If you have a high blood pressure, when the heart pumps, it must pump against high blood pressure. Okay, so the heart will have to work more, and that's a sign of afterload. Does this make sense?
So in hypertension, the blood pumps against a more contracted the arteriole, therefore increasing the P2, right?
Yeah.
And afterload.
So I've explained this in terms of Poiseuille's law again, which is cardiac output, and I've made flow into cardiac output. I've made P1 into upstream pressure, which is pressure in the left ventricle. I've made P2 into arterial pressure, which is pressure in the general arterial system. If I have high pressure in the arterial system, then that means my pressure gradient is less. That means my flow or cardiac output in this case will be less, because flow is directly related to pressure gradient. The other setting is aortic stenosis. Okay, so the left ventricle contracts, the blood goes through the aortic valve into the general circulation. If that aortic valve is very narrow, the ventricle will have to work a lot to pump that blood, right? So the ventricle will have to pump all of that blood against a very narrow ventricle, and that's very difficult. And so that will change cardiac output. So let me show you here. Yeah. If this is the same curve we've been discussing the whole time. This is preload. Now this is the normal. As I'm increasing preload, I'm increasing cardiac output. This is Frank Starling. Now, if I decrease afterload, what will happen? The pressure gradient will increase. That means cardiac output will increase. That means for the same amount of preload, let's say I have a preload here, but I vasodilate, and this way my blood pressure drops. That way the heart will have to work less to pump blood. That means cardiac output will increase. So if I decrease resistance, my afterload, my cardiac output will increase here. Okay. So decrease afterload will cause an increase in cardiac output by shifting the Frank Starling curve to the left. An increase in afterload will shift the curve to the right to decrease cardiac output for the same preload. Because preload is not changing, this is not Frank Starling. Does this make sense?
Can you repeat about the preload again, about the changing in afterload, what happened without, or changing in the without changing preload, you are changing the cardiac output.
Mm-hmm.
Okay. I didn't understand it.
Okay, no problem. The main concept we discussed for preload was that preload is the amount of blood in the ventricle before it contracts. The more blood I have in the ventricle, the better the contraction. Okay, as long as I'm following this relationship, I am following Frank Starling. So let's follow this curve here. This normal curve, let's follow it. Let's draw a line here, and let's say this is a preload or preload of 1. And let's say this is a preload of 3. This is a cardiac output of 5, and this is a cardiac output of 10. Okay. For me to go from, let's say I move from this point in the graph to this point in the graph. That means preload increased. That means the blood in the ventricle increased. And this increased the contraction. This is Frank Starling. However, let's say let me erase. Let's say I'm at a preload of 3 and I don't change this preload. I still want to increase the cardiac output somehow. One way is I shift so the only way I can increase cardiac output is by moving this curve up. Now the question is, what will move this curve up? The last slide we said contractility. We can increase contractility by sympathetic stimulation or by giving digitalis. This will shift the curve up to increase cardiac output at a preload of 3. The alternative is to vasodilate. The vasodilation will decrease afterload, and this will increase cardiac output at the same preload. When preload and cardiac output go in the same direction, this means you're following Frank Starling. In this case, the preload is the same, but cardiac output increased. So preload doesn't change, cardiac output increase. This is not Frank Starling. Does this make sense?
But since contractility increases cardiac output, which means that there should be increase in afterload, because afterload, it is the contractions of the heart in pumping blood.
Yeah, okay. We're discussing cardiac function right now, okay? So there's two arms of cardiac output. There's cardiac function and there's vascular function. We are only discussing cardiac function now, okay? At the end, we will discuss cardiac function and vascular function put together. But right now, I need you to understand that that stroke volume is an indicator of systolic function, that preload, contractility, and afterload influence stroke volume. Preload influences stroke volume by Frank-Starling mechanism. Contractility increases cardiac output or decreases cardiac output at the same preload. Afterload is dependent on resistance. Okay, so afterload is determined by total peripheral resistance. If I decrease resistance, I decrease afterload and I increase cardiac output. I'm not touching the preload. If I'm not touching the preload and I'm increasing cardiac output, this is not Frank-Starling. Does this make sense?
Areez, I have one question, please.
Okay.
How can we increase the preload with only contractility? Like, how? We need more blood, so
Okay.
Can you please repeat this? I didn't get it.
So when we were discussing preload, what did I tell you will determine preload?
Cap.
Venous return.
Venous return, because preload is the amount of blood in the ventricle. Venous return is the amount of blood coming into the heart. That means venous return will also determine the amount of blood in the ventricle. If I have high venous return, the ventricle contains more blood, the ventricle contracts more. This is Frank-Starling. Contractility and afterload are different. They will shift the curve. If I increase contractility, I will increase cardiac output, but I won't touch preload. If I decrease contractility, I will shift the curve down here. I won't change preload, but I will change cardiac output. The same with afterload. If I vasodilate, cardiac output will increase, but the preload will stay the same. Venous return won't change. If I vasoconstrict, afterload will increase, so cardiac output will decrease. So I've shifted this curve down here, but preload is not changing. Okay? Does this make sense?
Yes, thank you.
Okay. So just to summarize, they will show you a curve like this in the exam, okay? What you need to know is as long as I'm on one curve, as long as I'm moving along one curve, I'm following Frank-Starling, because preload and cardiac output are changing in the same direction. As preload decreases, cardiac output decreases. As preload increases, cardiac output increases. When I'm shifting the curve, I'm not changing preload, but I'm changing cardiac output. This means this is not Frank-Starling. If I'm shifting the curve up, I'm increasing contractility or I'm decreasing afterload by vasodilation. If I'm shifting the curve down, that means I'm decreasing contractility or increasing the afterload. Does this make sense? This is a summary of the whole thing. Okay. And this is just examples of conditions of diseases where you have increased afterload or decreased afterload. So if you vasodilate or decrease resistance, this will decrease the afterload. This will increase the cardiac output, right? Because if you decrease afterload, cardiac output will increase. So for example, in Paget's disease, what happens, I think you guys discussed this as MSK briefly, that in Paget's disease, there's a lot of osteoblastic activity and a lot of osteoclastic activity. And because there's so much activity, the bones require a lot of blood flow. This causes formation of AV shunts in the bone. AV shunts are basically arteries that drain directly into the veins without arterioles. This will decrease the resistance. If the resistance is decreased, the cardiac output will increase. Okay? This is Paget's disease. Another disease you guys took in biochemistry is beriberi. Does anyone know what beriberi is? This is just to integrate a lot of other disciplines. He won't ask you about beriberi in the exam, but I'm curious. Does anyone know what beriberi is?
Vitamin B1 deficiency.
Vitamin B1 deficiency or thiamine deficiency. You see this in alcoholics. Why does it decrease peripheral resistance? Does anyone know this? I'll give 5 riyals to the guy who can answer this question. No, but that's too not unspecific, Yahi. Sorry. So what it does is, think about it like this. Glucose enters the cell. Glucose, if it's used, it should be one way glucose can be used by the cell is for it to be generating ATP. The first step in that process is converting glucose into pyruvate by glycolysis. Okay. Now pyruvate has 2 options. It can go into the mitochondria to be put into the Krebs cycle, or it can go into lactic acid production in anaerobic conditions. In the Krebs cycle, the first pathway glucose can, the first step in the Krebs cycle is conversion of pyruvate to acetyl-CoA by an enzyme called pyruvate dehydrogenase. Yes? Pyruvate dehydrogenase requires TLCFN, thiamine lipoic acid coenzyme A, FADH2 NADH. Because you don't have thiamine, pyruvate dehydrogenase doesn't work. If pyruvate dehydrogenase doesn't work, that means pyruvate has to go into the lactic acid production. Then you have accumulation of lactic acid. And if you remember from your autoregulation, lactic acid causes vasodilation because it's a metabolite of the cell. This will cause this accumulation of lactic acid will cause vasodilation, which will decrease resistance. Okay. And this is why, as well, for example, if an alcoholic comes to a clinic, for example, with hypoglycemia, alcoholics are susceptible to developing hypoglycemia. You will think, okay, I'll just give the guy some glucose. But if you give the guy glucose, the guy can die because he doesn't have thiamine. And if he doesn't have thiamine, all of that glucose will go into lactic acid production. And so when you're correcting hypoglycemia in an alcoholic, you should always give them thiamine first. So this is just for your interest. Now, this is a summary slide of what we've all just discussed, okay? First, we said we need, by cardiac function, we mean stroke volume. How do we regulate stroke volume? We regulate it by CAP. Preload, contractility, afterload. Preload is determined by venous return because venous return determines the amount of blood in the ventricle. If there's more venous return, there's more preload, there's more contraction. This is called Frank-Starling. Frank-Starling is when I'm moving along one curve. If I'm moving along one curve, I'm changing preload and I'm changing cardiac output in the same direction. That is Frank-Starling. If I shift the curve up, I am increasing cardiac output for the same amount of preload. That means I did one of 2 things. I either increased contractility by sympathetics or digitalis, or I decreased the afterload. If I shift the curve down, that means I decreased contractility for the same preload. Then that means this is not Frank-Starling. That means I did one of 2 things. I either increased the afterload by vasoconstriction, or I decreased contractility by either ischemia of the heart or some drugs like that inhibit sympathetics, or congestive heart failure can do this as well. This was a whole summary of cardiac function. We've discussed cardiac function. It's finished now. Okay. Is there any questions on cardiac function? No? Clear? Anyone else? No? So you basically just need to know how this curve changes. Okay. I saw your guys' slide. It was a lot of detail. You don't need that much detail. Okay. You just need to know that how, when I'm moving on this curve, I'm following Frank-Starling by altering preload. What alters preload? Venous return. If I keep the same preload and I increase cardiac output, That means either increase in contractility or a decrease in afterload by vasodilation. If I decrease the cardiac output for the same volume or preload, that means decrease contractility or increase afterload by vasoconstriction. That's all you need to know about cardiac function, okay? Because yes, this is exactly what I've shown you. Okay, so as you move from A to A2, you increase preload, you increase cardiac output. This is a quiz for all of you. I'm going to ask you a question and then you can type in the chat. If I move from A to A2, is this Frank Starling? Yes. Because as I'm increasing preload, I'm increasing cardiac output. What will make me shift from A to A2? Does anyone know this? Increase preload. And what determines preload? Venous return. Good. So if I increase venous return, I will shift from here to here. I'll show you later on in the lecture that venous return depends on blood volume. The more blood volume I have, the greater the venous return. The greater the venous return, the greater the preload. The greater the preload, the greater the cardiac output. So for example, saline infusion that I've put here would increase the blood volume. Increased blood volume would increase the venous return. Increased venous return would increase the preload, which would increase cardiac output. So this would be saline infusion, okay? This would be, for example, I'm decreasing preload, so I'm decreasing blood volume. This would be like hemorrhage or something, or you're drawing blood for some reason. Any decrease in blood volume. Now, let me ask you this. I've moved from point A to point B. What have I, is this Frank Starling? Moving from point A to point B, is this Frank Starling? No, because I've kept preload the same, but I've increased cardiac output. What are the two options I have to do this? Either I increase contractility, that's one. There's another option, or I decrease afterload. What determines contractility? I told you sympathetics and drugs. So if I administer digitalis, that will shift the curve from A to B. Or I give an alpha blocker, because alpha receptors are in the vessels, right? They control vasoconstriction, vasodilation. If I block the alpha receptor, I will cause vasodilation. If I vasodilate, I will decrease afterload and I will increase cardiac output. So these two scenarios, administering alpha blockers or administering digitalis, would move point A to point B. Now, let's go from point A to point C. What happened here? Is this Frank Starling? That's the first question you should always ask. No, don't give me a scenario. Just the first question when you're looking at these graphs is ask if this is Frank Starling. Is this Frank Starling? No. That means it's either contractility or afterload. It's either a decrease in contractility or an increase in afterload. That means this could be heart failure, which would decrease contractility. If I block the effects of sympathetic system, I would decrease contractility. The other option is I give a drug that stimulates alpha receptors. If I stimulate alpha receptors in the blood vessels, I will cause vasoconstriction. I will increase resistance, and the curve will move from A to C. Is this clear, all of this? This is cardiac function. This is all you need to know, okay? Yes, okay. Now we're moving on to venous function, and then we're going to combine the two, okay? Does it make sense to you? Could you repeat beta blockers? Sure. Beta blockers, the sympathetic nervous system stimulates increases contractility of the heart by activating beta receptors. If I block these beta receptors, I will block the effect of the sympathetic system. That means I would decrease the contractility. Okay. Now, when we're moving on to venous function, does it make sense to you that because the left heart and the right heart are connected in series, that their outputs have to equal one another? The arterial system and the venous system are connected in series. That means that they have to have the same output. The output of the arterial system is cardiac output. The output of the venous system is venous return. That means venous return has to equal cardiac output. Does this make sense? Yes. Good. So because this is a major concept you need to know. Let me give you an example. Let's say a guy has ventricular fibrillation. Okay. Let's say we take a guy and we put him into ventricular fibrillation. His cardiac output will drop to 0. What will happen to venous return? It will become 0, because if cardiac output is 0, then you're not having any flow back into the heart. Let's go the other way now. Let's say I block the IVC and SVC. So I block the venous return completely. If venous return drops to 0, what happens to the cardiac output? It drops to 0 as well. So venous return has to equal cardiac output. Okay. Venous return is also called vascular function. Okay. So we discussed cardiac function. Now we're discussing vascular function. And you need to know that cardiac output is regulated by cardiac function and vascular function. Okay. Do you remember this, this equation Q equals P over R? So Q equals P1 minus P2 over R. P1 is upstream pressure. P2 is downstream pressure. I told you to keep this equation in mind. Now we're going to apply it to the venous system, okay? So we're going to take this equation and apply it only to the venous system. In the venous system, what is downstream pressure? Where is the blood going in from the venous system? It's going into the right atrium. That means that the downstream pressure, P2, is right atrial pressure, okay? What is P1? P1 is something we call mean systemic filling pressure. So let's explain this now. Your body, let's say, has around 5 liters of blood. Your heart is pumping blood as well. Let's say we put the heart into fibrillation again. The heart stops beating. Is there still some blood in the circulation? Yes, there is. Obviously, there is blood in the circulation. This blood in the circulation is generating a pressure. We call this pressure mean systemic filling pressure. Okay? So that's mean systemic filling pressure. It's when the heart stops, how much blood is in the circulation is generating a pressure. That pressure is called mean systemic filling pressure. We can measure mean systemic filling pressure in experiments, and it came out to be 7. Don't ask me how this happened. You don't need to know that. This mean systemic filling pressure is the amount of pressure generated by the blood in the circulation when cardiac output is 0. The value is 7. Okay. So now what have we done? We've contextualized this equation, Q equals P1 minus P2 over R, to the venous system. We said downstream pressure is right atrial pressure. Upstream pressure is PSF. Then does this make sense to you? And this is the flow would be venous return. So lots of people get confused about equation of venous return. It's basically the same as this equation, but we've just contextualized this equation to the venous system. We've made flow into venous return, P1 into PSF, P2 into right atrial pressure. Does this make sense up until now? Yes, what's PSF? Okay. Do you agree with me when I say that not all of the blood that you have is in the heart? Because I always have blood in my circulation. Not all of the blood is in the heart. If I stop the heart, there's obviously still some blood left in my circulation. This blood in the circulation is pushing against the wall of the vessel, and so it's generating a pressure. That pressure is called mean systemic filling pressure. That's all you need to know. Like Dr. Abdul Jabbar is not going to ask you about oh, explain this to me and explain what mean systemic filling pressure is. You just need to know that is the amount of pressure generated by blood in the circulation. It is the upstream pressure in the equation of venous return. That's it, finish, okay? Because other than that, like this other information is useless, to be honest. Now, we're gonna look at this curve. What is the difference between it and blood pressure? Blood pressure depends on cardiac output and resistance, right? If the resistance and cardiac output were, if I eliminated cardiac output, there obviously still is some blood left in a dead person, for example. He has no cardiac output. He still has blood in his circulation. That blood is generating a pressure. That pressure is just called mean systemic filling pressure. Can you please explain oncotic pressure? Oncotic pressure is due to do with proteins in the circulation. So, you know, osmosis, the amount of, the more solutes you have, the more the osmotic pressure. That's basically oncotic pressure. The more solutes you have, the more proteins you have, the more the pressure. So it's not related to this topic right now, okay? Now, does this make sense to you now, given this equation? We're gonna come back to venous return, okay? PSF minus right atrial pressure. Does this make sense that as right atrial pressure increases, venous return will decrease? Because pressure gradient will decrease. Does this make sense? As right atrial pressure increases, I decrease the pressure gradient. That means I decrease venous return. Yes, okay. Good. Now, let's say I keep increasing right atrial pressure and I reach 7. At this point, right atrial pressure becomes 0. Venous return becomes 0. This is mean systemic filling pressure. Because we said that PSF is 7, if right atrial pressure increases to 7, then there is no pressure gradient. If there's no pressure gradient, there is no venous return. So do you agree with me that this x-intercept here should be mean systemic filling pressure?
Yes.
Okay, so everyone follow so far, because this is very, very important, okay? Yes, okay. Good.
So right atrial pressure is the same as mean systemic filling pressure.
Right atrial pressure is the downstream pressure for venous return. Mean systemic filling pressure is the upstream pressure for venous return. If I increase right atrial pressure to the same value as mean systemic filling pressure, I will have no pressure gradient. If I have no pressure gradient, I have no flow. Flow in this case is venous return. So I have no venous return either. Does this make sense?
Yes.
Okay. Now, we looked at what alters cardiac function, right? The CAP, the contractility, afterload, preload. Now we're going to look at what alters venous function. Now, you remember I told you to remember an equation for me, which was compliance equals volume over pressure. If I rearrange this equation, I will get pressure equals volume over compliance. PSF, mean systemic filling pressure, is a pressure. That means I can substitute PSF into this equation. And so therefore PSF would equal volume over compliance. Does this make sense? Compliance equals volume over pressure. I've rearranged for pressure. PSF, as PSF is a pressure, I can substitute PSF into this equation and make it so that PSF equals volume over compliance. I just wanted to do this just to help you remember the factors which change PSF. Okay, PSF, again, remember, is the x-intercept of this graph, right? So if we change PSF, we will shift the graph either to the right or to the left. Now, from this equation, we can get some important relationships, okay? PSF is directly proportional to blood volume. If I have increased blood volume, I increase PSF. This will shift the curve to the right because PSF is increasing. Does this make sense? Because PSF is directly proportional to volume. Does this make sense?
Yes, makes sense.
Okay, good. PSF is inversely related to compliance. Compliance is how much a vessel stretches, right? So this is venous compliance, by the way, not arterial compliance, venous compliance. If I constrict the veins, I will decrease their compliance, right? I will make them more rigid. So if I decrease compliance, I will increase PSF. So if I want to shift the curve to the right, if I decrease, constrict the veins, I will shift the curve to the right because I'm increasing PSF. Does this make sense? Or I'm going to repeat one more time. Compliance is how easily a vessel stretches. If I constrict the veins, I am decreasing compliance. Because compliance is inversely related to PSF, I will increase PSF. If I increase PSF, the curve shifts to the right. This is just in the veins. We're talking about the veins right now. Does this idea make sense to you? Okay, anyone else? Okay. So you need to know this as well. This is a very important point for your exam because Dr. Abdul Jabbar can ask you, for example, what would move the venous return curve from this point to this point? Either an increase in volume or an increase in venous tone. Increase in volume like saline, we discussed this, right? So that saline increases venous return. Why does saline increase venous return? Because saline increases blood volume. Blood volume would increase PSF. PSF would increase venous return. So by shifting the curve this way, I will increase venous return. The other way is that sympathetic stimulation will constrict the veins, not the arteries, okay? We're talking about the veins. It will constrict the arteries, compliance will decrease, venous return goes up because PSF increases, sorry. And this will shift the curve to the right. So right shift of the curve, blood volume increase or venoconstriction. The opposite is true as well. So to decrease PSF, I should decrease blood volume or I should increase compliance. So I should dilate the veins. Does this make sense?
Yeah.
Okay, because this is, so we're pretty much done with both of the lectures, to be honest. It's not that much to do. Okay. Now, let's focus on this one here. This is a bit more tricky to understand, but hopefully we can make it make sense. Now we talked about blood volume, we talked about venous compliance. Now let's talk about resistance, systemic vascular resistance. If I vasodilate, that decreases resistance. That will increase venous return by increasing the slope of this curve. Now, how do you remember this? How I remember it personally, this may not work for you, is that this curve is if we calculate the slope of this curve, the slope is giving us flow over pressure. Okay, so let me make it a bit more clear. If I calculate the gradient of this curve here, okay, let's say I'm taking this black line. Yeah, the gradient of this curve is flow over pressure. That means that the gradient of this curve is 1 over resistance. Because resistance, if Q equals P over R, if I rearrange the equation, I get R equals P over Q. That means this equation, Q over P, is 1 over R. Do you guys know what conductance is? Conductance is the opposite of resistance. So resistance is how difficult it is for blood to move, for example. Conductance is how easy it is for the blood to move. So the slope of this curve is telling us conductance because this is 1 over resistance. When I increase the slope, I increase the conductance, therefore I decrease resistance. If I decrease the slope, I decrease conductance, that means I've increased resistance. This is a bit of a tricky concept. Does that make sense, or should I repeat?
So the output over the pressure is the conductance, which is inversely proportional to resistance.
Yeah. So if I increase the slope of the curve, I am increasing conductance. If I'm increasing conductance, I'm decreasing resistance. If I'm decreasing the slope of the curve, I'm decreasing conductance and I'm increasing resistance. Similar to compliance. Compliance is how easily something stretches to accommodate volume. Okay, we're not talking about compliance. Compliance is to do with the veins. We're talking about arterioles here. Okay, we're talking about if arterioles constrict, the resistance increases. The increased resistance will decrease the conductance. The conductance is the slope of this curve. If I decrease conductance, that means the slope will decrease. If I vasodilate, the resistance goes down, but the conductance goes up. That means the slope increases. Can we say right atrial pressure is venous return? Yes, you can. So let's let me go back here. So you see this here. You see this third point. Cardiac preload is determined by left ventricular end diastolic volume. Left ventricular end diastolic volume is the same as left ventricular end diastolic pressure. That's the same as central venous pressure. That's the same as right atrial pressure. That's the same as PCWP, which is pulmonary capillary wedge pressure. All of these mean the same thing. They are an indication of how much blood is coming back to the heart. So sometimes on the axis, you'll see preload. Sometimes you'll see left ventricular end diastolic pressure. Sometimes you'll see right atrial pressure. They all mean the same thing. Okay. So, but does this concept of resistance make sense? Okay. So just to recap, if we take this curve here, this black curve is the original curve. So let me question you guys on this. If I shift this curve this way, what's happened to PSF? I've increased PSF. If I've increased PSF, what have I done? What's the equation I told you guys? So what situations will lead to this curve shifting to the right?
Increased venous return.
Yeah, so I've increased venous return. Okay, look. We said PSF equals, okay, so we need to explain this again. We said PSF is the x-intercept of this graph, right? Increased blood volume, exactly, yes. Now, for venous return, you have to divide it into two points, okay? First is shifting of the curve. So the curve can shift to the right or the curve can shift to the left. The second point is decreasing or increasing the slope of the curve. Right now, we'll discuss shifting the curve, then we'll discuss the slope of the curve, okay? This we agreed on, this x-intercept is PSF. Everyone agreed on this because at this point, right atrial pressure equals the mean systemic filling pressure, venous return goes to 0. So this is mean systemic filling pressure. Then we came up with this equation of PSF equals blood volume over compliance. That means if I increase blood volume, I will increase PSF. If I increase PSF, I will shift the curve to the right. The other scenario is if I decrease compliance by venoconstriction, I will increase the PSF like this, and the curve will shift again to the right. So if the curve shifts to the right, you have two scenarios: increased blood volume or venoconstriction. If the curve shifts to the right like this, that means I've decreased PSF. So either I've decreased the blood volume or I've increased the compliance by dilating the veins. So if the curve shifts to the left, you have two options: decreased blood volume or increased compliance. Does this point make sense?
Because decreased blood volume means that not as much blood is going back to the ventricle, and increased compliance is that more blood stays in the veins, right?
Yeah. So in this scenario, I told you that I've shifted the curve this side, right, to the right. What's happened to PSF? Remember in cardiac function curves, I told you always question why, always the first question you should ask is this Frank-Starling? For venous return curves, the first question you should ask is the PSF increasing or decreasing or staying the same? If the PSF is, where's my curve? Where's my, yeah, there, okay. Yeah. The first question you should ask for venous return curve is the PSF staying the same? So in this scenario, let me draw this here. This is the new curve. Is the PSF staying the same, increasing or decreasing?
Increase.
It is increasing. That means, according to the equation that we came up with, PSF equals blood volume over compliance. That means to increase the PSF, I either increase blood volume or I either decrease compliance. So this is either an increase in blood volume or a decrease in compliance. Let me draw this scenario. This is the new curve. What happened to PSF?
Decrease.
It decreased. That means if we follow this equation, I either decrease blood volume or I increased compliance by venodilation. Does this make sense now?
Yeah, so PSF is the hydrostatic pressure in the blood vessels, we can say.
Yeah, basically, it's just the blood in the vasculature which generates a pressure.
Yeah, thank you.
Experimentally, we've identified it as being 7. Okay, good. So I think this point on PSF makes sense. So I told you that you should divide venous return curves into 2 sections, right? Shifting of the curve and then slope of the curve. So that was shifting of the curve, blood volume or compliance. The other point is, notice that this curve is changing as well, but is PSF changing? It's staying the same. That means I'm altering resistance. If I increase the slope of the curve, like this curve is less steep, this curve is more steep, right? That means I've increased the slope of the curve. That means I've increased conductance. Conductance is 1 over resistance, i.e. it's the inverse of resistance. That means if I've increased conductance, I've decreased resistance. That means I've vasodilated. Conversely, if we look at this curve is less steep. That means I've decreased conductance. That means I've increased resistance. That means I've vasoconstricted.
Can you repeat conductance definition?
Okay,
It's
good.
how easy the blood flow.
Yeah, so if I have a blood vessel here, this is P1, this is P2. The pressure on this vessel, vasoconstriction, vasodilation is resistance, okay? The compliance is how easily this blood can move through. The resistance is trying to prevent this, okay? So conductance is how easily the blood moves through. Resistance is how difficult it is for the blood to move through. So they're exactly the opposite, okay? So if conductance is increasing, compliance is decreasing. If conductance is increasing, resistance is decreasing. If conductance is decreasing, resistance is increasing. Inversely proportional. That's like the best definition. Okay. So if the slope of this curve, yeah, in this case we're talking about arteries, yes. So what I've done during this whole lecture is when I've talked about the veins, I've always said venoconstriction, venodilation. If I say vasoconstriction or vasodilation, I'm talking about arteries, arterioles specifically. Okay. So the slope of this curve tells us conductance. If the slope of this curve tells us conductance, and if I go from here to here, the slope is increasing, that means conductance is increasing. If conductance is increasing, that means resistance is decreasing. Okay. If conductance is
Quick
increasing,
question, Areez.
yeah.
In the graph here, when the right atrial pressure increases, cardiac output decreases. Is that because not as much blood is returning from the veins because of the pressure gradient?
Yeah, so I told you that venous return determines which, okay, so if I draw this curve here, this is the cardiac function curve. If I draw this here, and then as I increase, venous return, we said equals cardiac output, right? Venous return is determined by PSF minus right atrial pressure, the pressure gradient. If I increase right atrial pressure, that means the pressure gradient decreases. That means venous return decreases. That means preload decreases. That means cardiac output decreases. Okay. So I want to get this point on resistance clear because this is a point of confusion as well. So shifting of the curve, remember blood volume or compliance. Changes in slope of the curve is conductance. Conductance is the inverse of resistance. If I make the curve more steep, that means I increased conductance, decreased resistance. I have to vasodilate. If I decrease the slope of the curve, that means decreased conductance, increased resistance. That means I vasoconstricted. Does this make sense? Yes, yes. So 2 people, 3. Okay, good. The last point, concentrate on this one. Remember that systemic vascular resistance also changes cardiac function. So I've drawn the cardiac function curve for you. What happens to the cardiac function curve if I vasodilate? The cardiac function curve if I vasodilate. What happens to the cardiac function curve if I vasodilate?
Moves to the right.
To the right. Okay, so if I vasodilate, what happens to the afterload?
Decreases.
Decreases. If the afterload decreases, that means I shift the cardiac function curve this way, right? We said as
Wait, how does vasodilate decrease the afterload? I mean the preload. It increases the preload, vasodilate. So more blood is coming back to the heart.
but it also shifts the cardiac function curve. We'd said how I explained this to you is that I looked at cardiac function in isolation. I looked at venous function in isolation. Now we're going to combine these two together. You're absolutely right that in vasodilation also increases venous return.
Yeah.
So let me give you an example. Let me erase all of this.
This is confusing.
Okay. No, you've got the right idea. Okay. So let's say this is the original. This point, the original, is the original cardiac output and venous return equilibrium. Okay. You follow me so far?
Yeah.
If I vasodilate, what will happen to the cardiac function curve only?
Cardiac function increases because
It will shift
less
up,
pressure
right?
on the heart. Yes, because less pressure on the heart to push the same amount of blood.
So the cardiac function curve shifts this way. What happens to the venous function curve if I vasodilate?
Decrease? No, it increase.
If I vasodilate,
You mean venoconstrict or vasoconstrict?
vasoconstrict.
Vasoconstrict decreases the blood flow back to the heart.
Yeah, so I said if I vasodilate, sorry. If I vasodilate, what happens to conductance?
Increases.
Increase.
Increases. That means the slope increases, right?
Yes.
Do you follow me so far? Does this make sense? Okay. That means I shift from this point of equilibrium to this point. I go from A to B. So you're right. Systemic vascular resistance, arterioconstriction or arteriodilation changes both cardiac function and venous function. But how I explained this to you, because that's how I find it simple, is that I explained the effects on cardiac functions separately. I explained the effects on venous function separately, and now we're trying to combine them together. Okay. So does this diagram make sense? Does this shift make sense?
Yes.
Okay, to you as well, the guy who asked the question.
Yeah, so the answer is vasodilation causes more venous return.
Yeah, it causes more venous return. It does.
So the cardiac output increases, so it moves upward, the graph.
Yeah, but the cardiac output would increase even if the cardiac output moves this way, because even if I kept preload the same. So let me go here. This is the cardiac function curve. I've removed the venous function curve again. Let's say I have this preload, okay? I'm not going to change this, okay? This is my original cardiac output. If I'm moving along the curve, would you agree that this would be Frank Starling if I move along this curve?
Yes.
This would be Frank Starling. If I move this curve up, I get an increased cardiac output at the same preload. Is this Frank Starling?
No.
No. So I have two options here. I either decrease the afterload by vasodilation, or I increase contractility.
Good question. So cardiac function graphs move up or down. Venous function can increase the slope, decrease the slope, or move right or left, right?
Yeah, exactly. In the graph, how can we have the same venous return with different cardiac output? I'm explaining a theoretical concept in isolation. So I wanted to explain cardiac function in isolation. Afterload and vasodilation affects both cardiac and venous function. You're right. But what I find easier to do, and how the professor also explained it, is he explained cardiac function separately. He explained venous function separately. Now, because we finished all of it, now we can discuss those two together. So if someone gives you this graph on cardiac function, this increase in, and he gives you this shift in the curve this way, you will say this is an increase in contractility or decrease in afterload. Obviously, in reality, the preload also increased because the slope of the curve went this way, right? The conductance increased. But in this curve, you're not considering that. You're only considering cardiac function. You're not considering venous function in this curve. If I draw venous function here, and if I say, let's say, for example, let's do this. Let's say this is the original venous function curve. This was our original equilibrium at A, okay? I changed afterload. That means I increased the slope of this curve like this. I increased the slope of the curve because conductance decreased, because conductance increased, resistance decreased. And I also shifted the cardiac function curve up. That means the new equilibrium point will be here.
So B is when we exercise.
Mhm.
Vasodilation, that's when B happens.
Yeah. Make sense?
How about if
Yes.
we shift it to the black line?
If B shifted to the black line here,
Yeah, that's
then
normal.
you vasoconstriction. If B was normal and you go from B to A, then this would be vasoconstriction, because you're decreasing the slope, you're shifting the curve down. Make sense?
Yeah.
So A goes to B because we vasodilate, decreasing the afterload.
Yeah.
And also we increase the amount of venous return. So that also increases the conductance and increases the slope.
Yeah, easy. Finish. It's not that difficult. So once you know the cardiac function curve, how it changes, the cardiac and the venous function curve, how it changes, then you can sort of relate everything together. So I hope all of this makes sense so far. Okay, so we've discussed shifts in the curve. You remember this formula, please. PSF equals blood volume over compliance. So it's directly related to blood volume, inversely related to compliance. And then remember that shifts in slope are because of arterioconstriction or arteriodilation, changes in resistance. Okay. Now this is basically a review slide. Now we've discussed all of cardiac function in isolation. We've discussed venous function in isolation. Now we have to combine them together, because I told you cardiac output and venous return are the same. If cardiac output drops to 0, venous return will drop to 0. If cardiac output, venous return drops to 0, cardiac output will drop to 0. That means they both have a deep interplay with one another, and this regulates cardiac output. Does anyone remember what changes cardiac output? We said the measure of cardiac output we will use is stroke volume,
Contractility.
and what else?
Afterload, preload.
The cap, right? Contractility, afterload, preload. This is the revision basically. Which of cap does venous return determine? Does anyone know this? Preload. Easy. Review in shifts of cardiac function curve. Shifts in the cardiac function curve are due to changes in inotropy, contractility, or changes in afterload, vasoconstriction, vasodilation. If there's increased inotropy or decreased afterload, the curve shifts up. If there's decreased inotropy or decrease in afterload, the curve shifts, or increase in afterload, the curve will shift down. Okay. Review of shifts in venous return. Shifts in venous return means changing PSF. Increased blood volume causes increased PSF to increase venous return. Decreased blood volume decreases PSF to decrease venous return. Compliance, if I veno-constrict, I will decrease compliance. I will increase PSF, I will shift the curve to the right. If I venodilate, I decrease the PSF, the curve shifts to the left and venous return will decrease. So these are the shifts in the curve. Also remember, as we just had this discussion, systemic vascular resistance, changes in resistance, alter both. It alters the slope of the venous return curve and it shifts the cardiac function curve up and down. Okay. So I hope you're getting the hang of this now. Yeah.
Venous return is the PSF minus the right atrial pressure, right? Okay, so when we decrease compliance, we increase PSF, increasing the gradient, increasing preload. Okay, that makes sense.
Makes sense? So just remember, so the reason I emphasized on these equations is just to get you into an idea. So if you remember that Q equals P1 minus P2 over R, then you say, okay, let me contextualize this equation to the venous system. P1 becomes upstream pressure, which is PSF. P2 becomes downstream pressure with right atrial pressure. Q is venous return. So instead of memorizing the equation, you can just understand this. Okay. So now you've understood cardiac function, shifts in cardiac function, and now you've understood venous return, shifts in venous return plus slope. Now let's go, now you're ready for this diagram. This diagram sort of puts everything together, okay? Now, let's consider cardiac function alone once again. So let's practice this, okay? This is cardiac function. I'm considering it alone. I decrease contractility. So I decrease the contractility. This will shift the curve down. Let me ask you, is this Frank Starling?
No.
No.
No. If I increase contractility, I increase cardiac output for the same preload. So this is not Frank Starling either. The two factors that I told you to regulate this, that increase contractility, is sympathetics. Catecholamines is basically epinephrine, norepinephrine, okay? So sympathetics plus digoxin or digitalis. What decreases contractility? Sympathetic inhibition. Uncompensated heart failure. Heart failure also decreases contractility. Another point is ischemia. Ischemia also decreases contractility. Let's
And
move
beta
on.
blockers, do they have anything to do with
Yeah, they will
constriction?
they would also decrease sympathetic inhibition, right? So beta blockers would inhibit the sympathetic system and decrease contractility. Okay, so that was cardiac function. We reviewed it once again. This is venous function. For venous function, let me just make it again, just to sort of stick this into your brain. PSF equals volume over compliance. If this is PSF, because at this point pressure gradient is 0. So PSF would be 7. If I increase PSF, isn't venoconstriction increasing venous return because it reduces compliance? Yes, you're right, Isra. Exactly. So what you're getting confused with is that sometimes we discuss about venoconstriction, sometimes we say vasoconstriction. Vasoconstriction, I'm referring to arterioles. Venoconstriction means veins, basically. Okay, so those are two different things. Venoconstriction would increase venous return. Vasoconstriction would decrease the slope of the curve to decrease venous return. Okay, so just remember this. This is the normal curve. Yeah, so if this is the normal curve and I shift this to, let's say, 9, that means PSF increased. That means I increase blood volume or I decrease compliance. Okay, that tells you here. So the curve shifting to the right would either be due to increased blood volume, like saline infusion, or it would be due to an increase in venous tone, venoconstriction. A decrease in PSF or a shift in curve to the left would be due to a decrease in blood volume, like hemorrhage, for example, and decrease in venous tone, so venodilation.
Areez, in the second graph, it says on the x-axis right atrial pressure and diastolic volume. We don't mean that the right atrial pressure and the gradient, we mean the PSF, right?
You remember this?
Yes.
Yeah, so I told you that left ventricular end diastolic volume is the same as left ventricular end diastolic pressure. That's the same as central venous pressure. That's the same as right atrial pressure. And that's the same as pulmonary capillary wedge pressure. Sometimes, I don't know why they do this. They just change the name of the axis just to confuse people. But the concept is exactly the same. It doesn't really matter. Don't concentrate on the axis. Look at what's happening in the curve. Maybe Dr. Abdul Jabbar will change the axis and you will say, oh, this refers to central venous pressure, not right atrial pressure. It means the same thing. Because central venous pressure is the amount of blood in the veins of the thorax. The more veins, the more blood you have in the veins of the thorax, the more venous return you're going to have, because those veins drain into the right atrium. If the more blood you have in the right atrium, the more blood you're going to pump to the lungs and then to the left ventricle. So right atrial pressure will also determine left ventricular and diastolic volume. So they're both all interconnected with one another. But they just change the axes to confuse students. Yeah, it does. Roshdan, you're right. So an increase in systemic vascular resistance. This is only mentioning inotropy because I'll show you why in a second. So did you all of you understand this now, right? You have it ingrained into you. You shift in the cardiac function curve, shifts in the venous function curve. You all remember this?
Yes.
Okay, good. Okay, alhamdulillah. Now we're gonna move on to, remember in the last slide I told you that, recall that systemic vascular resistance alters both. This third curve shows you that. Okay, so this continuous red line is the cardiac function curve baseline. This straight blue line is the venous function curve, and this is the normal equilibrium. Let's say I not veno, vasodilate. What happens to afterload?
Increases because more venous return.
Afterload.
Yeah, I mean preload. Afterload decreases.
Afterload decreases, because the way I like to approach it is I look at cardiac function. I've always, in first year up until now, whenever I look at a curve, I look at the cardiac function curve first. The first question I ask is this Frank Starling? If it's not Frank Starling, that means contractility or afterload. Then I go and look at the venous function curve. I say, okay, what is PSF doing? Is it increasing or decreasing? If it's changing, that means I'm altering blood volume or compliance. If the slope is changing, that means I'm altering resistance. So I always approach in this sequence, okay? So just, I guess, I don't know, it's up to you really. So what I do is I will look at this cardiac function curve and let's see the shift up. Is this Frank Starling? It's not Frank Starling. That means it could be afterload or decrease afterload or increase contractility. Okay. Then I look at the venous function curve. PSF is the same. That means I'm not changing blood volume. I'm not changing compliance. That means because the slope of the curve is higher, that means conductance is higher. That means resistance is lower. So this is the new equilibrium point. If I increased afterload by vasoconstriction, I will decrease the cardiac function. I will shift the cardiac function curve down because of the increased afterload. Also, I will decrease the slope of the venous return curve. So total peripheral resistance can be increased plus sign by vasopressors. Vasopressors are basically alpha-1 receptors. Okay, your alpha-1 receptors cause contraction, right, of arterioles. If you stimulate them by vasopressors, you cause constriction. Exercise. This is an important topic for you guys to remember. I'm not going to cover it in much detail during this lecture, but in exercise, what you have is your muscles you're working a lot, right? Your skeletal muscles. This generates a lot of lactic acid and a lot of adenosine because you use up the ATP. ATP gets converted to ADP, ADP to eventually adenosine. Then those metabolites accumulate and they cause vasodilation. This vasodilation will decrease the total peripheral resistance. And that will have this effect on the curve. Right? So you move from here to here. AV shunts, I already told you, like you have in Paget's disease, for example, you have numerous AV shunts forming in the bone. And this will cause this shift up to the curve. Anemia as well, decreased RBC mass, because anemia, if you don't have enough RBCs, you don't have enough oxygen delivery to tissues. If you don't have enough oxygen delivery to tissues, that means tissues suffer from hypoxia and they use autoregulation to dilate the vessel. And this causes decreased peripheral resistance. So all of this curve together, now it makes sense to everyone?
Yes.
Okay. So just remember, okay, so cardiac function, remember the cap, venous function, remember volume over compliance, and remember conductance. Okay, now we have the last slide, which is we're gonna look at both of these curves and how they change in certain situations. Point A, the black line is the normal cardiac function. The black line of the venous return is the normal venous return curve. Now I'm just gonna ask you what happens, okay? When you exercise, your sympathetic system gets activated. That means a sympathetic stimulation via beta-1 receptors of the heart increase contractility. So the curve moves this way. Okay, so you go from A to B. Sympathetics constrict the veins. Okay. This will increase PSF to shift the curve to the right. You will go from B to C. Sympathetics also vasoconstrict via alpha-1 receptors. This will increase the slope of the curve like this to point D. So the new equilibrium is point D. Okay. This is an exercise.
One more time, please, Areez.
Okay. This is the normal equilibrium, point A. Sympathetics, when you're exercising, sympathetics increase contractility of the heart. So you shift the cardiac function curve to the left. So you go from point A to point B. Sympathetics then veno-constrict. This increases PSF to increase the pressure gradient for venous return, which shifts the curve up here to point C. Sympathetics, during exercise, as I told you, muscles are releasing lactic acid and adenosine, which caused by the metabolite mechanism of autoregulation, it vasodilates. So you have decreased TPR or increased conductance. And so the slope of the curve increases and you go to point D. Does this make sense in exercise?
So from point B to point C, right? There's also the graph shifts to the right, the venous function shifts to the right because of the vasodilation, right? Vasodilation and venoconstriction.
Venoconstriction. Then C to D is decreased systemic vascular resistance. Okay, does this make sense, everyone?
B to C is because of venoconstriction.
Yeah, because if okay, so
and C to D is for what?
C to D would be what's happening from C to D. Okay, let's figure this out. Let's say I go from point A to point B. What changed? Did the cardiac function curve change or the venous function curve change?
Cardiac function.
The cardiac function curve changed. Is this Frank Starling?
No.
No. So it's shifting up. So it's either decreased afterload or increased contractility. Right?
Yes.
So let's say it's both of them. Let's say because the sympathetics are stimulating the heart, increasing contractility, and because in exercise you have decreased resistance. Let's say both of those mechanisms cause the shift from A to B. Okay, let's say this. You following me so far?
Yes.
Okay.
Areez.
Yes.
Oh, sorry for the interruption. The graph that Dr. Abdul-Jabbar gave us is different from this. Like the lines, I don't know how to explain it.
Yeah, some lines are drawn like this, some lines are drawn like this.
Yeah.
Like, it doesn't matter. It doesn't matter. It's the curve, same curve.
Oh, man.
Can
you please explain in that picture? I guess it's better for us to understand because he only explains in that picture.
No, this is from his slide.
Yeah, I understand. Okay, fine.
No, I cannot. I'll explain it on this first and then I'll explain it on that. Okay.
All right.
Okay, no problem. But do you follow on this?
Yeah.
Okay. So yeah, look. So if I venoconstrict the sympathetic, by the sympathetic I venoconstrict, PSF increases, right? Look at this. PSF increases. That means I increase the venous return. That means I go from B to C. You following so far?
Yes, and B goes up because of the preload, increased preload.
What, sorry?
B moves to C because of the increased preload.
Yeah, because the venous return determines the preload.
Because of venoconstriction, there is more preload.
Yeah.
So it goes to the right and up.
Yeah. Okay. So now notice from C to D, what changed? Did the cardiac function curve change or venous function curve change? The venous function curve changed, right?
Yes, but even the cardiac function goes up, yani.
No, but right. Did it change as in, did it shift up or down?
No.
Okay. So remember what I told you in the beginning, venous return determines preload, right? So as I'm going, changing venous return, I'm only moving along the curve. That means I'm always following Frank Starling. That means because that's because venous return determines preload, right?
Yes.
So I'm on the same cardiac function curve. The PSF is the same, but the slope increased, which means conductance increased, which means resistance decreased. Okay?
Mhm.
So I hope this makes sense. This is for exercise, okay? Now let's go to heart failure. Heart failure, what happens in heart failure? So point A is the normal equilibrium point. In heart failure, I told you cardiac contractility goes down. So the curve will shift to the right. So you go from point A to point B, okay? Then what will happen is that the sympathetic nervous system will kick in because it will think, oh, the heart is failing, I need to maintain blood pressure. So it will venoconstrict and it will vasoconstrict at the same time. So vasoconstriction will increase systemic vascular resistance to increase the blood pressure, and venoconstriction will increase PSF to increase venous return. So the shift in the curve is due to venoconstriction, but then also noted that this curve is less steep. So conductance is down. That means resistance is up. So you go from point B to point C. Does this make sense?
The slope is affected in because of the arteries. Now has nothing to do with the veins, right?
Yeah, it's our vasoconstriction.
Yes.
The curve will shift because of venoconstriction. So does this both of these diagrams make sense to you? Everyone? Okay. Okay, so this is the normal equilibrium point, right? I think this is very easy to think about, the shift from A to B, because cardiac contractility decreases. That's easy. The sympathetic nervous system then thinks that the heart is failing, because if the heart fails, cardiac output drops. If cardiac output drops, the mean arterial pressure will drop. If the mean arterial pressure drops, the sympathetic system is activated. The sympathetic does two things. Firstly, it venoconstricts. Venoconstricts, okay? We said that if you venoconstrict, you shift the venous return curve to the right by increasing PSF. So this shift of the venous return curve to the right is because of venoconstriction, okay? The second thing that happens is that the sympathetics vasoconstrict the arterioles, because you know that arterioles, if they vasoconstrict, they raise the mean arterial pressure. So in an attempt to raise the mean arterial pressure, the sympathetics will vasoconstrict. This will decrease conductance, which means the slope of the curve goes down. That means you get this picture here, okay? Also, the renin-angiotensin-aldosterone system, or the RAS system, kicks in to increase blood volume. It increases resorption of sodium in the kidney. So the RAS system will increase blood volume. So you have a further increase in the PSF to a further shift in the venous return curve. So this is summarized here. So this shift in the curve is due to venoconstriction, so decreased venous compliance. It's the decrease in slope is because of increased systemic vascular resistance. The increased volume is because of the RAS system. The increased volume will also shift the curve to the right. So does this make sense?
Yes.
Okay. I'm sorry for taking too much time, sorry, okay? So now
No problem.
So now this is just a summary of the lecture. I started off the lecture by telling you that systolic function is, sorry. So for B to C, there's a right shift and decrease in the slope. Yeah, exactly. The right shift is because of the blood volume and the venous tone. The slope is because of the resistance, okay? So this is exactly, so this slide is exactly what you need to know for this lecture, okay? I told you that we measure cardiac function by stroke volume. Then I told you the factors which regulate stroke volume with the mnemonic CAP: preload, contractility, afterload. Preload refers to the Frank-Starling curve. is determined by venous return. Contractility is changing cardiac output without changing the preload, is determined by the sympathetic nervous system and drugs like digoxin. Afterload is determined by venoconstriction. It is increased in things like hypertension. Okay. Changes in the Frank-Starling curve, as we're on the curve, we're following Frank-Starling. If we move up the curve, we increase contractility or decrease afterload. If we move down the curve, we decrease contractility or increased afterload. Then that was for cardiac function. Then I told you that cardiac output is regulated by both cardiac function and venous function. So then we contextualized the equation Q equals P delta P over R to the venous system. And we came up with an equation of venous return. Venous return equals PSF, upstream pressure, minus right atrial pressure, which is downstream pressure, over resistance. Then we substituted PSF into the compliance equation and came up with this relationship. PSF equals blood volume over compliance. If blood volume increases, like saline infusion, PSF will increase, shift the curve to the right. If compliance decreases by venoconstriction, PSF will increase to shift the curve to the right. The opposite will apply as well. So venodilation will shift the curve to the left, hemorrhage will shift the curve to the left. So that's the one, that's the shifts in the curve. Then we talk about the altered slope. The slope is the conductance. If the slope decreases, conductance decreases, resistance increases. That means I vasoconstrict, constricted the arterioles. If the slope increases, that means if the slope increases, that means conductance increased, and so I decreased resistance. That means I vasodilated. And we also said that systemic vascular resistance alters both cardiac and venous function. Then we talked about changes in both of these curves with exercise, and we came up with this, and cardiac failure, okay? And we came up with this. So initially, increased contractility and decreased resistance to shift the cardiac function curve. Then you have venoconstriction to shift the curve from B to C. Then you have decreased resistance to shift the curve from C to D. For heart failure, initially you have decreased contractility, which shifts the curve from A to B. Then you have increased blood volume, venoconstriction by sympathetics to shift the curve. And you have increased resistance to decrease the slope of the curve.
Areez, the left one.
Sorry.
Can you go back to the graph? From B to C increased sympathetics and C to D increased resistance.
Decreased resistance.
Decreased. Okay, thank you.
So A to B is the initial response, but then after that is like the sympathetic kicking in and normalizing it as much as
thinking
possible.
about it in terms of, oh, this takes 5 seconds and this takes longer, is not really accurate, because your body is doing so many things at the same time. So the sympathetics, as soon as they're regulating cardiac output, they're also going to the veins to venoconstrict. So all of this is happening at the same time. But just physiologically, when we're studying it, we like to study it in stages just to make it easy for us to study.
Yes.
So that's my lecture, okay? I hope that didn't take too long.
Thank you so much, Areez.
I wish you all the
Thank
best
you.
for your exam. Yeah.
Thank you, man.
Okay.